Good morning to those on the West Coast and good afternoon to those on the East Coast, and welcome to the Social Determinants of Health webinar. This is a collaborative presentation by members of the Capacity Building Assistance Provider Network. We are a network called the CPN mostly of 21 national organizations that provide support to strengthen community-based organizations, health departments, and healthcare organizations in their high-impact HIV prevention initiatives. And this is all at no charge to you because we're fully funded by the CDC. So what you're hearing today
Dina, we lost you.
Can you all hear me now?
Yes.
Yes.
Wonderful. So we've got some wonderful presenters for you today. We have 3 of our member organizations represented. We have California Prevention Training Center. We have Primary Care Development Corporation. And we have Proceed Inc. And we have 3 wonderful people from California: Tim Vincent, the manager of the Capacity Building Program; Jadorn Wright, the trainer TA specialist; and Patrick Piper, another trainer TA specialist. So just a wonderful group. I'm Dina Murphy, and I'm the lead for the Capacity Building Assistance for Healthcare Organizations and part of the National CPN Resource Center. We also have the wonderful Dina Quinones, the Senior Project Manager from Primary Care Development Corporation, and Vanessa Arias Martinez, the Program Manager, Training and Distance Learning from Proceed Inc. So I'm going to turn it over to them, and please let us know if you have questions, and we'll do our best, as Cindy said, to answer them. But thank you for joining us.
Okay, Tim Vincent, I think you're going to take over from here.
I am. So good morning and good afternoon, and welcome to this webinar that we're calling Addressing Social Determinants in HIV Prevention and Care, Power and Place Matter. So we need the first slide up. There we go. And I just want to start by saying we were very impressed and also very moved by the fact that many of you signed on and so many of you wanted to be part of this particular webinar at this particular time. And so I think that there's a real interest in thinking about some of the complex ways in which determinants that are large really factor into our HIV prevention efforts and really our HIV care efforts. So we're going to be talking about that. And as Dina said, we're going to be talking about that also from a perspective of what people can do at a CBO level, what people can do at a health care organization level, and what people do at a health department level. So one of the first things we're going to do, too, and we're going to do this throughout this webinar, is we're going to post some polling slides. And so the first polling slide, if you can set that up, Cindy, is to ask people where their primary setting of their work is. Are you mostly affiliated with a community-based organization? That's A. B is healthcare organization. C is health department. D is something else. So we're seeing the vote tallies come in. And we'll give it just maybe a couple of seconds for you to respond to that. And people are telling me their other work settings. So great. We see some universities, some people from federal qualified health centers. We see somebody from a legislative office. Some other people did say health departments, university, UCHAPS. So great. We're having a lot of people from lots of different ways in which they do the work. I see food outreach, some university, NACHO. That's fantastic. So I'm not seeing. Are you all seeing this too? Can we end the poll and then broadcast it?
Absolutely.
So are they seeing? Is everybody seeing these results as well then?
Yes, Tim.
Okay,
Yeah.
great. So it looked like we have a good mix of people from health departments, community-based organizations, a little bit less from healthcare organizations, and then there's a lot of other. And I am just, again, impressed to see the amount, the diversity in the work that you do, the different communities that you're working for and with, and then the different geographic regions that are also represented here. So hopefully this will be relevant to all of you who are listening. I'm going to start also by talking about the fact that most of us who are doing this work are well aware that we're using the National HIV/AIDS Strategy as a guide to focus our efforts in reducing infections, improving health outcomes overall for people living with HIV and people vulnerable to it, and to reduce HIV-related health disparities and inequities. And we're also really thinking about how we can work more collaboratively with our partners in order to achieve this equity. So that's really what our focus is. And so social determinants have a way of really impacting all of those goals. And especially with goal 3, which is about reducing HIV-related health disparities and inequities, that we recognize that in this point in time in the epidemic, that it's clear that these goals can't really be reached without examining larger factors that influence the transmission and risk and the ability to manage HIV. So, and also here in the goal, it talks about the fact that structural level approaches are really needed and also need to be supported in order to diminish the current inequities that we witness around the country. And I would imagine just seeing everybody who's on here that you see them probably in different ways, depending on where you work and where you live. But this can't really be done without really recognizing the complex manner in which things like stigma and discrimination really create barriers to people who are most vulnerable and most marginalized here in the U.S. And this is, I would say, and I think that our group would agree, that this is really a time that we really have to create strategies to support the biomedical advances that we've made and to really create pathways for people who are most need these tools, not only so that they can access them, but they can endorse them and they can use them in the best way and the most successful way for them to achieve a better health outcome. So that's what we're here for, and that's what we're going to be talking today about. And in order to move into this talk around social determinants of health, I really wanted to spend maybe about 5 minutes talking about creating a common language. And so when we talk about social determinants of health, some of these words are also associated with it, about race, disparity, social justice, poverty, class, different things. And also for people who were on the quiz earlier, some of the things like education and housing and all of those things are also factors that matter. And so before I get into that particular topic around social determinants of health or what that means, I wanted to just talk about the definition of health in general. And so when we are talking about health, and in order to really look at the way in which social determinants of health factor into HIV prevention, we're looking at health as a holistic, expansive definition that really includes the spheres of social well-being, physical well-being, mental well-being, spiritual well-being. And so it's not really so much, it is about the absence of disease, but it's not really focused on that. So when we're talking about social determinants of health, we're really thinking about how they impact kind of all of these different spheres. And another thing that I think is important when we're talking about creating health equity is to recognize that particular places in this holistic approach may be more meaningful to people at different times in their life. And I know that for all of you who are on this call, it may be that social well-being is more prominent in your life than spiritual or the other way around. And so really it's about how do we keep our communities as healthy in the most holistic way possible that would really make them less vulnerable to HIV transmission or acquisition, and also to manage HIV if they have it. So when we're looking at health equity, I just want to talk about a couple of other definitions. We're really looking at this as the goal for most of us here, is that we're really wanting to strive for equity in the HIV prevention and care work that we do. And on this slide, which I think is important, is to really recognize that equality is not the same as equity. And so if we're talking about something, like a biomedical advancement like PrEP, it may be that it's there, like in that first section of the slide, the left part of the slide. But in order for it to be equitable, people may need help or ways that they can touch it, access it, use it that might be different from other people. And so when we're talking about equity, we're talking about how do we create those pathways or those boxes, if you will, so that people can use what is available to them in the most successful way possible. When we're talking about health inequity, we're really talking about the fact that the ways in which that gets distributed has to do with, the topic of this thing, power and place, and that there may be a causality, there is a causality implied, that maybe for historical reasons or significant laws or policies or geography, that people aren't able to have equity around their health benefits or their health outcomes. And so that's really what we're talking about when we're talking about health inequity. One of the things that drives our work is this, which is around health disparity, which is really about looking at the variations and disproportions in health status for individuals and groups. And in many ways, that's more of a descriptive term and doesn't always imply the fact that there may be something unjust or unequal or this inequity that exists, but could imply that there's inequity that exists. And so I know that most of our work right now, again, just thinking about those particular terms that I just said, are really about looking at the health disparities that exist in our particular jurisdictions and thinking about, are there some health inequities that are explaining that, and what might they be? One of the ways that we look at how health is determined at all is really looking at, if we're wanting to examine those inequities, we might be looking at, are there individual behaviors that people are doing in particular places that make them more vulnerable to, either, again, HIV risk or not being able to manage HIV in an effective way? Or are there biological or genetic factors? Are there social or environmental factors? Is the social order or the way that people can access their power different in different places? Is there a physical, environmental aspect to it that makes it difficult for people to achieve their optimal health? Or is it really about the health services that are existing that make it difficult for people to, again, achieve an optimal level of health? So that's usually how we look at this. The three that are in green are really more about the social determinants of health. But before we get into that, I want to put another poll out to you. So if you could put that out, Cindy, because I want to ask the group and see that they're here with me. When you think of the determinant of health that you believe is most responsible for disparities related to HIV, what one would you say it would be? Would you think it would be individual behaviors? Do you think it's about the biology and genetics that really impact the disparities that you see in your communities? Do you think it's a social environment? Do you think it's a physical environment? Do you believe it's the health services? So I'm believing, again, what we can end this and broadcast it for people. If are they seeing it again? I want to make sure. There you go.
Okay, everything's being broadcasted in real time.
Oh, good, good. I don't want it to be a secret, a secret vote. So anyway, so great. So it looks like you, what's, again, overwhelming and interesting is that you all, or most of you, said that it was a social and environment that really describes the disparities that exist. And so it really speaks to the fact that the work needs to be, or really is important that we support what we can do in a social environment to create more equitable experiences for people who are vulnerable to HIV and living with HIV. So the next thing I want to say is really the definition of social determinants of health, which really is here, which is talking about conditions in which people are born, grow, live, work, sometimes people say pray, and age, and including the health system, and that those circumstances are shaped by the distribution of money, power, resources at global, national, and local levels. And those are also influenced by policy choices that impact quality of life for better or worse. And so some of it seems very fixed. Some of it might be not so fixed or not so static, depending on where you live and what things you can actually change. But it is dynamic, and it is complex, and it sounds like from what everybody just described in the poll, or just answered in the poll, that this really is something that is significantly impacting the disparities that you see around HIV in your communities. And so one other thing I want to talk about is, or want to show you really briefly, is a video. And this is from a writer named Ta-Nehisi Coates, who talks about the fact that individual responsibility isn't enough and that we need to do more.
Okay, I'm going to go ahead and start it now.
Great. With the notion that individual virtue is somehow a match for the forces and the resources of a society angled in a particular direction, in this case towards white supremacy. I don't think individual virtue, which some people will call personal responsibility, is enough.
My parents will not get you there.
No. My parents were very virtuous and were very, morally and personally responsible. This did not change the fact that they lived in a community that was shaped by housing segregation. That you can't.
So it's structural.
My grandmother, raised 3 kids in the projects, sent all 3, of her young daughters off to college. She scrubbed white people's floors and went to school at night. And when it was time for her to buy a home, she had to buy a home on contract in a way that white people did not. That, decreased the ability of my family to accumulate wealth. No amount of personal virtue on the behalf of my grandmother would have stopped that. That's that goes to the issues of the state and the society.
Okay, I hope you were all able to hear that. I'm going to go back to your slides, Tim.
Great. So he makes a case for the fact that structural and larger factors are important, that they can't, that with looking at some of the historical things that have happened, that we need to address health outcomes in a larger level. I'm going to turn this over now to my colleague, Jadon Wright, who will be talking about the implications that this has with HIV prevention and care.
Thank you, Tim. So some of the reasons that HIV in particular is affected and interacts with the social determinants is because we have such a large intersection with so many social determinants. So things like racism, sexism, poverty, housing, all impact the way people are able to either protect themselves from HIV, acquire HIV, and then how they're able to access care after they become HIV positive, which I think is a little bit different than other diseases, and that's why it's significant for us to look at these disparities as they relate to HIV. One of the things that we wanted our slide is not showing. I'll just move on. Okay. Can you guys hear me better now? Okay, great. So it looks like one of our slides is not showing, which is fine. Another thing that we're all pretty familiar with, I think, is the continuum of care around HIV, that people are diagnosed, linked to care, retained in care, prescribed ARVs, and eventually reach viral load suppression. And this slide that I have here that was created by NASDAQ really shows that all of the determinants, social determinants and individual determinants, are actually impacting people at each stage of the care continuum. But we didn't want to just talk about people who are HIV positive, because there's also a big impact on people getting HIV. And social determinants in terms of how people acquire HIV are very impactful. So this slide is really to show both the HIV positive continuum of care and the prevention continuum, which you may or may not be as familiar with. But that really talks about linkage to primary care, screening for factors and barriers, retention in care and services, continued risk reduction, PrEP and PEP, and remaining HIV negative. And this slide is really intended to show how all of the social determinants are having an impact at both of these levels. So sexual orientation, stigma, family acceptance, gender equality, housing conditions, poverty, healthcare, access to education, race, are all things that are either helping people to stay HIV negative because they have support that they need, or impacting them as they acquire HIV and their ability to access further care. So we are going to have another poll. And this time, we're not going to give you the answers. You're going to write them in the short answer. And the question is, which social determinants impact your work on HIV most often? So we're just trying to get a sense of what you guys feel. And we know we heard a lot of social stigma, social and environmental issues. I see it filling up quickly. Poverty, stigma, trauma, racism, homophobia, access to employment and education. And I think we're going to be able to look at all of these answers a little later and see which one is really impacting us. But the truth is that these all interact, and there's an intersectionality between all of the social determinants, and that's what really makes HIV a bit different than other diseases. So thank you for your participation in that poll. What we're going to do now is we're going to have some examples, and the first one comes from a CBO organization and where they were able to impact social determinants in their work. So we are going to talk to Vanessa Ares Martinez, and she's going to give us our first example from a community-based organization.
Hi, good afternoon, everyone. So the organization that we selected to highlight is an organization called NJCRI. They were established in 1988, and they've had a really interesting trajectory in terms of looking to address the social determinants of health for their clients. So I'm just going to advance one of the slides so we can all look at the questions to be addressed. In terms of how they decided to make the decision to address the social determinants of health, in reality, it was something that came about by ongoing continuous quality improvement strategies when they were able to get feedback from the clients about some of the barriers to accessing and staying in care or accessing prevention services on a consistent basis. And so the organization engaged in some of these strategies of acquiring consumer feedback through surveys and focus groups, and they were able to funnel that information back to leadership, which was then used to develop what they call ancillary services. In terms of which social determinants of health they addressed, literally because they came up with, they decided to embrace a holistic approach to working with clients. They've addressed a number of social determinants of health, including issues of stigma, drug use, just the physical environment, things that folks have access to, transportation, access to a pharmacy, access to multiple health services outside of HIV prevention and care. So they were able to use the client feedback to develop these strategies alongside their clients. It was very much a partnership. In terms of the key actors, NJCRI not only used their clients to inform them of what their barriers were to accessing treatment and prevention services, but the staff also were able to contribute to the feedback. Leadership, so we're talking about the executive director, the clinical directors, and the board of directors were all involved in learning about what the clients say often get in the way, and as well as kind of giving back to how then do we address these issues. And then partnership. And so in terms of the multitude of services, this one-stop shop model that they've embraced, in that process of developing these strategies, they've also developed MOUs with over 60 organizations across New York and New Jersey. The organization is based out of Newark, New Jersey. And so that was key for them because not every service will be able to be provided by them, and so they wanted to make sure they had a connection, a direct connection with other organizations that could provide additional services where they could not. In terms of the action steps that they completed and they continue to utilize, they engage in surveys, client satisfaction surveys twice a year. They hold annual focus groups, and so those are kind of their main modes of communication with their clients, in addition to regular treatment team meetings and things of that nature. And so that kind of helps them to continuously refine their strategies and make sure that they're addressing things with the ongoing trends or new trends that pop up. In terms of the outcome of their impact, I'm going to change the slide here. The outcomes of their holistic approach is that by embracing this model, they were able to decrease stigma around accessing NJCRI services. For a long time, folks in the community knew that that was a place that you went to if you wanted to get tested for HIV or if you wanted to, if you were HIV positive. And so something that they decided to do was by incorporating so many other services, so mental health services and addiction services. They offer pediatric care, OBGYN services. They have an in-house pharmacy. Because they did all of that, now folks don't necessarily just associate NJCRI with a particular target group, and so they feel like they've been embraced by the community to a greater extent. And so folks don't hesitate to go there because they understand that there's so many services that could be received. They also embrace the use of technology, and so it increased communication among staff for improved delivery of services, meaning that when a client comes in, they're checked in electronically. That automatically pages anybody else in the building that is tied to that client that is supposed to see them that day, so that they don't lose someone in transition from one appointment to another. And then also this idea that all of this work that they've done to provide clients with things like washing machines to clean their clothes so that they, or a clothing pantry so that they have clothes to use for job interviews. They have a food pantry. They offer transportation services. They have a needle exchange program. So again, they're addressing all of these different areas for clients. And what they've been able to demonstrate is that because of that, they've seen same-day linkage to prevention services, including PrEP, by folks identified to be high-risk negative, has been at 96%. They also have an adherence rate anywhere between 93 to 94% for individuals living with HIV. And again, this idea that they are known in the community to be a provider of a multitude of services, including those for HIV prevention and treatment. And on an annual basis, they yield over 3,000 individuals for testing of HIV, viral hepatitis, and other sexually transmitted diseases with a 2% seropositivity rate. So they've really demonstrated kind of a consistency in trying to address their clients' needs, and I think that's what made them such a really great model organization for the community to look at. Thank you. So I'm going to turn this over.
Hi, Jadon. Are we heading back to you?
I'm sorry, go ahead.
Are we heading back to you, or are we moving to Dina?
Oh, we're going to move to Dina, who's going to talk about healthcare organizations.
Thanks, Dina. Sorry.
Great. Good afternoon, everyone. If you can just, I can't control the slide. To the next slide. Good afternoon, everyone. My name is Dina Quiñones from the Primary Care Development Corporation, and I'm really excited to speak with everyone this afternoon about the great work that we have done with one healthcare organization that is doing amazing work out in Boston, Massachusetts. And so the healthcare organization's name is Whittier Street Health Center, and they are a health center that provides comprehensive, innovative, and high-quality health care, focusing on equitable access to high-quality, cost-effective health care for diverse populations. And some of the social determinants of health that they are committed to working on are lower educational levels, employment, and access to care. And the majority of the work that we worked with them on was access to health care for not only their HIV positive patients, but as well as their HIV negative patients. And some of the ways that they address the social determinants of health is by having a cohort of community health workers that go into the communities and conduct outreach and link people to care immediately, not only within the health center, but as well with other community resources. They have prided themselves in having several relationships with community resources, including community-based organizations that they work with to provide comprehensive care for their patients. And in addition to that, they also help their patients obtain health insurance to continue to ensure access to care. In providing this work, Whittier realized and recognized that their staff needed to enhance their skills to be able to have the impact that they desired on addressing the social determinants of health. And so that's when our Director of Infectious Disease, the Director of Infectious Disease and Special Populations from Whittier, reached out to PCDC for training and technical assistance to support both management and their community health workers. And so what the director realized and was asking for were trainings, specifically skills building trainings for both their managers and supervisors of the community health care workers, but also for their community health workers as well, so that they can effectively provide a high level of service to their patients. But at this point, I just want to talk a little bit about what the process was before we actually began providing training and technical assistance. One of the things that we made sure to do was to have an extensive level of pre-planning and interviewing with both the staff and the workers who would be a part of the training to ensure that we would provide exactly the information and skills building component that was necessary on both levels for both supervisors and the community health workers. Once we completed these interviews, PCDC and Whittier then came up with a comprehensive skills building training plan that would address the needs of the supervisors and outreach workers that came up in the interviews that were conducted by PCDC. And so to ensure that both the supervisors can support the outreach workers and that the outreach workers can effectively have the skills and be comfortable in doing their job, to both connect their patients within Whittier as well as within the community resources. Some of the trainings that were provided were trainings around professional boundaries, managing chronic disease, accessing patient resources, crisis management, bias, culture, and values, as well as the basics of care coordination and working within a team. As I mentioned, Whittier is committed to providing comprehensive services, so they would often collaborate with community-based organizations in the community. When we saw that, we then also noticed that it was important that we provide these trainings with other fellow CBER providers that can address these issues that community-based organizations were providing. So PCDC also teamed up with our fellow CBER provider Proceed to provide some additional trainings for both a community-based organization that Whittier has been collaborating with over time, which also has proven to have been successful to make sure everyone can work together to not only serve the community, but also to work within a care team. Once those trainings were provided, we ensured that we kept in contact with Whittier, and we would often check in or additional trainings would be requested, where we would then also do refresher trainings as there would sometimes be a change in staffing to make sure everyone had the existing baseline information, but will also bring all new staff up to date so that they, again, can continue to provide the services that they needed, and that management can also support their community health workers as necessary. And if you can switch to the next slide. Some of the outcomes that were, when we worked with Whittier, that was reported back, are that community health workers gained increased confidence and knowledge on how to address patient population needs to link them to care. Community health workers and management staff learn different navigation and leadership skills from the various skills building training provided by PCDC. And community health workers also reported that they gain professional boundary and communication skills on how to work together within a care team to meet patients' needs and link them to care. In addition to being able to provide these services and these skills building training for the community health workers, some of the impact that it had on the patients and the services that they provided were increased number of people that were referred to the center for mental health and other issues. And community health workers also reported that they have a better understanding of medical and non-medical issues that they could make referrals for and are better at linkage to services both at the center and other programs that are not offered at Whittier. So it has been a pleasure working with Whittier, and we continue to make our services available so that we can ensure that we support the staff in their endeavor to address the social determinants of health that they are committed to in their community. And so then I'll end there and hand it over to our next example.
Thank you. Next we're going to have Patrick Piper, and he's going to talk about health departments and what they're doing to address social determinants of health.
Great. Thank you, everyone. I'm Patrick Piper. I'm with the California Prevention Training Center. The next work we want to highlight is that of state and local health departments, specifically work that was done in the state of Louisiana with the Louisiana Department of Health and Hospitals, Office of Public Health, STD/HIV programs. This is an initiative that the California Prevention Training Center is intimately involved with, as we were part of the training delivery team. So it's very close to our hearts, and let's tell you about it. So following some work that they had done, some initial assessment work, they did some literature reviews. They were very concerned about the disparities, specifically in 3 areas of Louisiana, and rates of STD and HIV. And so they did some interviews, they did some literature reviews, and determinants that they found were racism and homophobia and transphobia, and that they found that these were underlying causes of disparities. In short, they were barriers for people to be able to access services. So given these data, the Louisiana Office of Public Health STD/HIV programs formed a strategy to enable intentional conversations about racism and its effect on this disparity, and that included homophobia and transphobia. Stakeholders included both staff of the health departments and these 3 funded CBOs. They chose 3 of their funded CBOs. But they also included staff that might traditionally be overlooked, and that was staff that were responsible for clerical and support staff, admin staff, because they are also, they play a big part of creating a welcoming environment for LGBTQ clients. So, and input was also obtained from consumers. So they took all of that, and through a capacity building request, they were partnered with the California Prevention Training Center, who also partnered with the Center of Excellence for Transgender Health at the University of California, San Francisco. And based on the findings that we did of an initial assessment, we began developing a curriculum for a 2-day training called Deconstructing Homophobia and Transphobia. In 2014, 6 workshops were held as part of the Louisiana Capacity Building Assistance Strategy, and that was done as a component of CAPAS, or the Care and Prevention in the United States demonstration projects. So let's talk about outcomes. What they found was evaluations basically were administered immediately post-training, so immediately when the training was done, but then they did 6-month follow-ups down the road. And what they found were an increase in knowledge of institutional racism. So basically, people acknowledged that these isms were operating and that they were important issues that needed to be addressed. Self-efficacy, or the belief that they could engage in improving this system, increased. So people basically felt like, this is something we can do. We can have an impact on this. Self-efficacy to explain terminologies, including that of racial privilege, increased. And then finally, intentions to address bias related to racism increased. Those are all individual factors that were measured, but they also were able to look at structural factors. So these trainings, participation in these trainings was mandated. So that in and of itself is a structural intervention. Anytime that you mandate something, you know, and require your people to do it, that could become a policy. So following that, coalitions were strengthened and or new collaborations were built. So basically, staff of the trainings were charged with creating plans to create plans to address factors within the coming years. So they had to come up with these, you know, short-term goals that they would begin to address racism, institutionalized racism, homophobia, and transphobia. And as well, policies and procedures were altered or new ones were created. So for example, one of the attending agencies developed new orientation procedures and developed new conflict resolution policies. So these are the types of things that we're talking about when we're talking about coming at things with a social determinants perspective. This next slide I'm going to show you just illustrates that really changes in social determinants often require changes in the social context, policy or law, or environment. These can be considered structures, and they must be addressed in order for behavior change to ultimately occur. So we keep saying, you know, behavior change is individual ultimately, but the ability to engage in behavior change is often dependent on larger structures. So this diagram is based on work that was done. Whoops. Where is our diagram? No, the diagram's not there. Well, basically, I'll talk through it. If you guys can envision that let's see, what should be on this slide, no, not this slide, sorry. What should be on this slide are three categories. The first one is acceptability. So basically what this model is saying is that factors that when you're addressing social determinants or you're using structural interventions, the factors you're addressing fall under one of these three categories: acceptability, accessibility, or availability. So you guys try your best to follow me here. Acceptability is kind of an outer circle. So for example, if we need to change attitudes towards condom use, say the community just has, you know, they don't believe in condoms, they think that nobody should use them, then, you know, that needs to change because otherwise it's not supportive of the intended behavior. Similarly, if you're trying to decrease stigma around PrEP, for example. So if there's a stigma and if people feel like, oh, these people are just getting on PrEP so they can be sexually promiscuous, you know, you need to decrease those stigmas before the behavior change is going to be long-lasting. Following that is accessibility. So can I access, you know, the intended information or materials in order to be able to do something? So an example of this is the condom distribution programs. So say I have a condom distribution program and I'm distributing free condoms everywhere, but in this town, they keep them behind the pharmacy counter. Then the access to these condoms is being impacted, and therefore it's going to have an effect on people's ability to access condoms. Another example, we can talk about PrEP again. So PrEP might be out there, but if it's not made available to providers or education is not made available to providers, and the providers aren't discussing it with their patients, well then, patients aren't able to access it, and the intervention is not, you know, it's not going to be effective. I see that we're doing something on the side here to try and get this diagram up for you guys. So now the next level is availability, and the connection between accessibility and availability are closely related, but they're also very different. So availability refers to whether or not this information is available to the intended audience. So let's say acceptability for PrEP within the community is high. The community wants it, they believe in it, that's high. Availability refers to, is it even something that they are able to to get information about. So say that the providers, for example, have really negative attitudes toward PrEP, or they don't believe in its efficacy. Then they're not going to, like I said earlier, they're not going to agree with the strategy, and it's not going to be made available to the patient. So that is what the structural intervention would focus on, is, getting the education and building the self-efficacy amongst providers to be able to talk about PrEP. And I just wanted to note, thank you for that. There's that beautiful, the beautiful slide, acceptability, accessibility, and availability. And this really is just there to help us kind of compartmentalize some of these factors that we're talking about that may seem very big. What I wanted to point out, though, with my last example is you'll note that the priority population for PrEP is ultimately the people who might get on it, right? But you'll notice that the intervention was targeting a different population. That is the population of medical providers. So that, again, is highlighting that sometimes the focus is outside of individual control, and outside forces are really creating those barriers for the behavior change to occur. So with that, I just wanted to talk briefly about some strategies. And now we can remove that slide. Thank you. There we go. So interventions that are addressing social determinants, structural interventions, they all share these 5 components. And the first is they aim to increase individual resilience, such as motivation for change and self-efficacy, the belief that I can actually do something about something. Next, they really seek to foster a supportive community. So they do this through building coalitions, assigning duties to community members, and conducting community forums or town halls to share the successes. They improve access to quality health care, and specifically, with the topic we're talking about today with HIV prevention, treatment, and care, that really is a big issue. And so in the health movement, they strive to increase, often by changing policy, procedures, they strive to increase access to healthcare services. They typically have some component that is transforming an environmental context. So a really good example of this in my mind are the smoking cessation programs. If you think about it, it started with some concerned citizens. They brought up the issue, and then, the next thing we knew, you couldn't smoke in public places. Then smoking really became socially unacceptable. And in fact, in California, just a couple weeks ago during our election, California voted to raise the cigarette tax over $2 a pack. So that undoubtedly will have impact on how much, people can afford to smoke, which will have an impact on the number of people smoking. And then finally, collaboration is vital. Coalition building is one of the most important things that studies looking at structural interventions have found. And they seek input from members of, all sorts of sectors of the community, not just people specifically engaged in one cause or another. So while we understand these endeavors might require us to operate on a larger level than we typically have, specifically in HIV prevention, addressing social determinants is not only very doable, but also very necessary and probably never more important than it is in the present day and as we look toward the future. The good news is you don't have to do it by yourself. We are here to offer assistance, and to tell you more about that is Tim Vincent of our SIBA program.
Thank you, Patrick. That was really helpful, and all of you for sharing your examples and really thinking about how in each of those examples it seems like it was a very long-term process and a very comprehensive one that the CBOs, healthcare organizations, or health departments were engaging in. We're gonna have a couple of moments for questions and answers in a bit, but really I think you also understood, or hopefully got from all of us, that one of the ways in which we can help all of you or people who are wanting some support is through the capacity building assistance efforts that we can engage in, with you, depending on, whether you are a CBO, healthcare organization, or health department, that we are willing and able to do. We have a number of ways in which you can get a hold of us. But before I move into, the questions and answers, I want to pose one more poll, in kind of hearing everything that we have just described and some of the examples that were also offered to you. Cindy, can you put the poll up? Thanks. What's your commitment right now to addressing social determinants in your work? What are some of the things you'd like to do, or you'd like to see change, or you'd like to really move forward in the work that you're doing? Just maybe a brief couple of words or a sentence that you would write about what is your commitment to moving this work forward. Right. There's stuff about policy and advocacy. There's about empowering people. It's about getting PrEP offered through the local health department, really kind of changing some systems, it seems like, in order to do that. A lot of people talk about policy advocacy, resource allocation. I'm seeing about reduction of stigma and discrimination. I'm thinking about, I see something about break down barriers for people to maintain care, collaboration. And again, I understand, or I would imagine that you also understand the implications of some of these things are really about having collaborations with others, about really having some long-term assessment and some real long-term kind of change that can happen by some of the things that people described earlier in the examples, and other things about demanding equity and equality, somebody said. I'm just looking at some of these things. Again, addressing systemic racism and structural racism. So incredible commitment that you are all making, and again, not always an easy task, or an easy task, I would say, to do, and really takes the support of all of us, I think, as a network of people who are very committed to our communities and making sure that equity exists. There is one last, one last slide. One last poll I want to also open up one more time. And in thinking about what you would need to do some of those things that you're talking about that you'd really want to commit to, what would help you in your support? Would it be about getting more training and technical assistance about how to set that up or to do that successfully? Would you need organizational support? Would you need better community connections? Would you like some data on some of the social determinants and the ways in which they might impact your communities? Would you like some ideas that can be implemented in your community, things that other people may have done? Would you like some indicators or evaluation tools that would help? Or anything else? Resources, more funding. Yeah, so funding's an issue. I'm just reading these out so that with no particular order. A lot of funding, and somebody said something about the politics needs to change, or that what we're moving to needs to change. Access, agency support, funding. Yeah, I think people are thinking that they really need to find ways to fund this or move this so that this could be maybe the focus of some of the funding. It sounds like I'm thinking in this. I may be interpreting this. Organizational support and more funding. And then people did talk about connections with the community and the people who are impacted, really doing that. And somebody said something about mapping SDH. So keep typing, because we really want to keep this. We'll keep some of this data and really offer this to the group here who's on this. We do have trainings that we do on social determinants of health and structural level interventions. I know some of our other colleagues have other trainings that they do on specific issues. We do stuff on homophobia and transphobia, but I also know that there are others out there in the network who do specific stuff around cultural humility, some of the things that Dina and Vanessa talked about, but we also have other colleagues out there who may be even listening who have other really great ways to do some training in TA to help with some of the things that you're talking about. I know that this was going to be a time also for questions and answers, but we don't have a whole lot of time. So Cindy, how do you want to do that?
I believe we are going until 2:30, or am I not correct on that?
This was going to be, no, I thought we were actually going till it was an hour. I thought we were at an hour.
That's my fault. Okay, let's move to the Q&A pod. just, we can go ahead and do one of the questions, or no? You want to run the video?
So there are a couple things we can do, just to let you know that we want to make sure that we can answer these questions and send a response to you or a response to the group around the questions at a later time, which would be totally fine. I'm not sure if from my colleagues if there's anything else. Is there a particular question that they'd like to answer or make sure that they can answer before we end this?
And we can ask folks if you want to stay on for an extra couple minutes. We're going to show an awesome video on social determinants of health. If you can't stay with us, you can jump off, and there is a link to that video on the bottom pod on the bottom left side of your screen. But I'd love to show it here if y'all want to stay on for just a few minutes.
Yeah. So just to introduce this as a group that we were just talking about, this capacity building network and the social determinants of health work group, we created a video that talks a little bit about how social determinants are seen in the communities and some of the work that we've been doing. So we'd love to show you. So do we want to just launch that, and then again we'll get back to you with some of the answers to some of the questions that you talked about, and really want to just thank you all for being on this.
That's
Cindy?
a great idea. We can put together a FAQ and send it out to all attendees on the questions that were asked during this. And I'll go ahead and start the video.
And you'll access the slides by downloading them, and and you can also have a link to the SDH video. It's on the left bottom screen, so you can do that. So you'll have the slides and access to the video after this.
Correct. And I will leave this screen open even after we end for those that want to download anything.
And it will be also recorded. Okay? Thanks.
Yes.
Stigma.
Give it
Lack of
just a second to
access.
start.
Stigma.
Lack of access. Difficulty with insurance.
Transphobia.
Competing priorities like housing, lack of food, or unemployment.
Racism and unconscious bias from providers.
These are just some of the challenges responsible for current HIV-related health disparities.
We are increasing the percentage of persons living with HIV who know their status, are linked to care, achieve viral suppression, and reducing death rates. Although there have been decline in HIV diagnosis for women, people who inject drugs, and heterosexuals, the epidemic among gay and bisexual men and transgender communities remains severe.
The National HIV/AIDS Strategy, or NHAS, updated to 2020, has become the roadmap for collective action in the United States. NHAS has 4 goals: reducing new HIV infections, improving access to care and health outcomes, reducing HIV-related health disparities, and achieving a coordinated national response. In order to achieve these goals, social determinants of health, such as stigma, discrimination, education level, and geographic region, must be addressed.
HIV is a public health priority with large-scale impact and known strategies to address it.
CDC funds the Capacity Building Assistance Provider Network to provide free program services to the HIV prevention workforce. We help to strengthen the workforce to achieve the goals of the National HIV/AIDS Strategy.
We work with health departments, community-based organizations, and healthcare organizations to provide free training, technical assistance, consultation, and information.
Capacity Building Assistance focuses on high-impact HIV prevention, designed to achieve greater success with federal HIV prevention dollars.
If you're a person living with HIV, you might be struggling with a variety of factors beyond just prevention or treatment of HIV. If you are unstably housed and or unemployed, these are all issues that we as providers and as health departments and as community partners need to be thinking about if we want to have a comprehensive approach to the epidemic.
As a street outreach worker, I get to work with the trans community and get to hear what their experiences are with accessing services. And some of them don't have a medical provider who understands where they're coming from, the experiences that they're going through, the language to use, the correct pronouns to use for them.
Trans-specific, culturally competent care
is very important. I know of an instance where a client just walked out of a clinic because she refused to be counted as a men who have sex with men category when asked about her sexual partners. I'm afraid the message she took home was, I don't count.
HIV-related disparities that I see in the work that we do often have to do with stigma. So where do I go in my community where people don't know me or don't know this about me or can't find it out about me because that's where I showed up?
We seek to create community where we bring together Black, African-American, gay men to define and design what community means for them. We seek to do that in non-traditional ways by meeting in unconventional venues such as someone's home, a restaurant, a barbershop, without this feeling of a health filter over top of it.
When it comes to working with American Indian and Alaska Native communities, it's important to realize that each of these communities have a specific language, have a specific culture, have a specific ceremony and religion. Recognizing that the relationship that capacity building assistance providers can have with Native communities has to be based on trust, has to be based on humility, and has to be a long-term relationship that you want to establish and to maintain.
Within our National Capacity Building Assistance Provider Network, a portion of our efforts are focused on examining and addressing social determinants of health that create implicit and explicit barriers to HIV prevention and care. Many of these are experienced on a larger structural and policy level as well, and can really exacerbate stigma that is experienced by many communities. Our services help providers make practice changes, create supportive policies and protocols, and to develop interventions that not only focus on the individual, but also on the provider, the organizations, and the community. We can help achieve the National HIV/AIDS Strategy goals and reduce HIV-related disparities. The United States will become
a place where new HIV infections are rare.
When they do occur,
every person, regardless of age,
gender,
race or ethnicity,
sexual orientation, gender identity, or socioeconomic circumstance will have unfettered access to high-quality, life-extending care free from stigma and discrimination.
Stigma,
lack of access, difficulty with insurance,
transphobia,
competing priorities.
Great, thanks for staying on, everyone, and taking a look at the video. I am going to leave this screen open for a few minutes, and I'm going to pull on the PowerPoint slides. So if anyone wants to stay on to download anything, I'll leave this open for another few minutes. But other than that, thank you very much to all of our presenters, and have a wonderful afternoon.